A very warm good afternoon to you. And today we'll be starting with some of the important things like NEET PG FMG cases, which are frequently to be asked, which are expected, and some of the important questions which are there always repeated, always on the mind of the examiners. So the best way to approach NEET PG and FMG through integrated study methods. So I'll be discussing with these things. So for the FMG and the NEET PG students, I would just like to have a bit of a concentration from their side so that they become aware of the facts, what would be expected, what is frequently asked, and how the questions are asked as far as the latest NEET PG, FMG, INICET, and MBBS students are concerned. More so for MBBS students because they should prepare in this manner. So you can see over here, there is a case which is given over here. A question is asked. A young patient presents with abdominal bloating, vomiting, and abdominal tenderness. Radiograph is shown below. So as you can see over here, there's a radiograph which is shown over here, and the radiograph you have to interpret. So most likely condition is. So over here, there are so many options given. Four of them: pancreatitis, small gut obstruction, toxic megacolon, intestinal malrotation. Now, what does this question test? This question tests the ability of a student to know what the radiological film is about. So as far as this question is concerned, the history is given, and from the history as well, you can just determine what the most likely option would be. But focusing on the image, you can see fluid levels at multiple places. So you can see a fluid level over here, you can see a fluid level over here, you can see a fluid level over here. So in case these fluid levels do exist in case of obstruction, the gut obstruction, and this is a classic example of picking up a radiological finding. And so the direct answer is the small gut obstruction because of the various fluid levels. Ability of a student to recognize where we see fluid levels, where we see the obliteration of the angles, costodiaphragmatic, costophrenic, where we see the perforation, say for example the subdiaphragmatic gas on the right side. These are some of the important things which are always there to be asked as far as the preliminary Indian medical graduate is concerned. So that is very important to recognize these important considerations as far as radiology is concerned. Now, another image-based question. A 33-year-old male has shortness of breath and he was admitted in ICU. The ECG shows abnormal wave. So this abnormal wave is a feature of hypokalemia, infarction, hypercalcemia, hypocalcemia are the conditions given. But as far as you can see over here, this is a normal ECG on the, over here, and this is an abnormal ECG over here. So what you are seeing over here, above the baseline, there is a ST elevation, and this classic ST elevation is seen in case of a clinical condition, very frequent, very life-threatening, and that is a MI. Myocardial infarction typically causes ST elevation. A very simple question asking a student to identify the ST elevation and associated with which condition. So ST elevation is associated with many conditions, and you have to remember what are U waves, what are the T waves, tall peak T waves, in which clinical condition we see delta waves. And as a result over here, as far as ECG finding is concerned, you have to recognize the ST elevation and the clinical condition with which it is associated. So these are some of the fundamental questions which are expected from you. Now over here, this is a clinical condition, image-based clinical condition, and they are asking you to recognize the deformity in this clinical condition. As you can see over here, this is the area of the elbow joint, and you can see the over here, this is the arm bone, and this is the forearm bone, and you can see the dislocation at the level of the elbow joint. So this is an area which you have to focus on. So this area you have to focus on, and this area shows that the lower end of the humerus has moved away from the elbow joint, and this is a classic example of an elbow joint dislocation. Ability of a student to recognize simple orthopedic problems is very frequently nowadays asked from an anatomical, osteological, or surgical perspective. So these are simple questions which are asked, which will be asked, like the fracture of the clavicle, like the dislocation of the shoulder joint, like the dislocation of the elbow joint, the ligament injuries, the ankle injuries, the knee joint injuries, the hip injuries, they are very frequently on the examiner's mind. So that is very, very important. Now, over here, again, an image-based question. It has been asked, and it will be again asked. What does this figure show you? What does this radiograph show you? So, what is it? So, you can see over here. This is a bone, which is the clavicle, and this is, see, you can see a breach over here. So, a breach over here. So, you can see multiple fragments of the clavicle. So, this is simply the fracture of the clavicle, especially at the lateral end of the clavicle. Ability of a student to pick up simple things, simple fractures, simple breaches, simple breaks in the bone, simple dislocations. That is very important on the part of a NEET PG, FMGE, INICET, and MBBS student to recognize simple orthopedic conditions which are just to be studied by you right from the first MB. You do not wait nowadays to reach orthopedics to detect these simple, and that is what the learning and the teaching from our basic sciences, paraclinical and clinical department should be. So it should be oriented in a manner that a student is able to recognize these clinical conditions by the end of first year only, not to wait for final year. That's very, very important. Now, moving to the other question, they asked you, what is this? This is the prostatic metastasis root. And what is the name given to the prostatic metastatic root? So they will be giving you many eponyms, and you have to remember the Batson's vertebral venous plexus. You know, elderly patients usually present with benign hypertrophy of prostate, BHP or BPH, but in some cases, it goes to the level of malignancy, prostatic CA, in which you find a hard indurated prostate, sometimes on per rectal examination of an elderly male. But more important than that is that the prostatic metastasis is usually seen. The prostatic cancer goes and metastasis to the, especially to the vertebral column, and it can go to the skull. And what is the root of metastasis to the prostate? In many cases, we have lymphatic root. In many cases, we have hematogenous root. But in prostate, the venous root is very important, and prostatic metastatic root is by virtue of an important venous plexus which lies in the vertebra, and which we give the name as Batson's vertebral venous plexus. So remember this thing, very important conceptual question asked, because patients with prostatic cancer sometimes present with, first of all, pain in the vertebra as a result of vertebral metastasis. So that is very important. Patient will not usually present with a problem in the primary area, a problem in the secondary area, metastasis far behind the region, and that can be a prelude and a diagnostic. I mean, say, once a patient complains with severe intractable pain, which does not go on with ordinary painkillers, and then you evaluate the patient, ultrasound, CT, MRI will eventually, in many of the cases, reveal prostatic cancer. That's how we deal with the Batson's vertebral venous plexus. And knowledge of vertebral plexus is very important as far as your surgery is concerned. Now, what are the types of questions which we get in your NEET, PG, FMG, INICT, UPSC? So, in a patient with DiGeorge syndrome, the cells predominantly affected are B cells, innate lymphoid cells, red blood cells, T cells. So, as far as DiGeorge syndrome is concerned, you can have the embryological basis of DiGeorge syndrome. I mean to say the deficiency of the formation of the pharyngeal arches along with the T cell defects, and as a result of which people, patients, young patients, the children usually have immunodeficiency. DiGeorge syndrome is due to maldevelopment of thymus, and the thymus is important for processing of importance of lymphocytes, the T types of lymphocytes. So over here, predominantly, I don't say other cells cannot be affected, but the T cells are very, very important because the processing of T cells occurs in the thymus. Thymus is not found in DiGeorge syndrome or malformed in DiGeorge syndrome. So the most important cells affected are T cells. A very important pathological question which has got its, I mean, say, genesis in embryology. So this is very, very important. Now, from ENT, you have to remember from a microbiological perspective, Laryngeal papillomas are caused by, the human papilloma virus. They cause so many things as far as the dermatological manifestations are concerned, as far as the gynecological manifestations are concerned, and as far as the surgical manifestations are concerned. We can have, from a dermatological perspective, the simple warts, the plantar warts on the plantar surfaces, the palmar warts on the palms, and then you can have warts elsewhere. As far as surgery is concerned, you can have the warts in the genital region along the anal canal, and especially in case of ENT, which is the question over laryngeal papillomas. HPV 6, 11, and 30 are very important. So the examiner here has given a choice 1, 2, 6, 7, and the most common is the HPV 6. So this is very important to know the subtypes of HPV virus and which HPV virus predominantly, what subtype causes what disease. That's very important. So you have to go into the micro level of certain questions. So you may be remembering HPV, human papillomavirus, as a whole, but that's not important. Important is that you remember the subsets of human papillomavirus and what they specifically and predominantly cause. So that is my point in making you understand over here. So as far as this question is concerned, you have to remember. Now, while doing dissection, anatomist shows his students dilated posterior middle wall of the neck of gallbladder. This is the Rob space, Morrison's pouch, Hartmann's pouch, caudate process. Now you come across various important things in anatomy. I mean to say the caudate process, the unsnaged process, the Rob space, the Morrison's pouch, the Hartmann's pouch, the rectovesical pouch, the rectouterine pouch, so many subphrenic spaces. Uh, my point over here is that you should specifically know what each term stands for. What is Traub space? What is the hepatorenal pouch of Morrison? What is the pouch of Douglas? Why do we find the caudate process? These are very, very important things. Maybe sometimes you do not pay much heed, much attention to these things. But believe me, these are the questions which are now asked. Important anatomical regions, the clivus, the external occipital protuberance, the internal occipital protuberance, the bregma, the inion, the glabella, so many things in, I mean, say, tubercle, so many important regions, points from surface anatomical perspective, Morrison's parallelogram from a perspective marking the kidney and also all those things. So my point is that you have to go in depth, in detail. So Hartmann's pouch you see as a dilatation in the posterior middle wall of the gallbladder, and it is a site for common lodgement of GB stones. Sometimes they get impacted over there. So you have to remember that the answer to this question is the Hartmann's pouch. But simultaneously, while doing this, maybe next time they asked you Morrison's pouch. So that is important. You have to remember and distinguish between all these things, what they mean by. Now, this question from pathology, the arrow in the slide below points to the Reed-Sternberg cell. So over here, there's a beautiful RS cell, which we could see in a pathological slide from a patient who presented hematological symptomatology. And here they asked you, what is this? A very simple, basic question. Some important cells. Why do we see LE cells? Why do we see Downey cells? Why do we see Reed-Sternberg cells? So as far as this question is, four options are given. I think a good student will not even look at the options because it is a very simple question. And lymphomas, Hodgkin's and non-Hodgkin's. Hodgkin's lymphoma is characteristically characterized by, I mean, say, RS cells, Reed-Sternberg cells. The question is simple. The answer is straight away there, and I don't think this need. But the ability to recognize RS cells, sometimes they may be giving you a question as far as this thing is concerned. Identify this type of cells. So you have to remember the Reed-Sternberg cell, which is a eyed and with bilobed nucleus, a prominent nucleoli. So this important thing, the RS cell, you have to remember as a feature of, I mean, say, Hodgkin's lymphoma uh, type, which is shown over here. Now, this is a radiograph which was given in one of the questions, and you had to identify what this is. So I have not given the radiograph question over here, but you have to see over here. You can see a disc desiccation at the level of L3, L4, and L4, L5, which is showing a compression on the spinal cord. So this is the spinal cord over here, and you can see that even at the L2, L3 level, there's a bit of a compression. So you can see the discs has gone posteriorly, and it has caused a compression on the, I mean to say, the spinal cord. Ability of a student to recognize disc desiccation, ability of a student to recognize spinal cord tumors, the ability of a student to distinguish metastasis within the vertebra. And this patient basically presented with a persistent low back pain for months together, and his straight leg raising test was positive, and ESR and other examinations were normal, because that's important. Myeloma ESR is increased, and PR examination in case of vertebral metastasis will suggest prostatic enlargement or a hard prostate. So this is a simple question which shows a disc desiccation at multiple levels, and you have to remember the Schmall's node, what we mean by Schmall's node, and MRI diagnostic findings are there. This is MRI, and this the ability to pick up the disc desiccation is what is frequently asked in NEET, PG, FMG, INICET. Then I would advise students also to update themselves with something which is very, very important, latest. What are the latest questions which are asked? Enteropathy associated T cell lymphoma. What is hypocomplementic UV syndrome? What are the important features of Repsom's disease? What is antisynthetase syndrome? What is hereditary hemorrhagic telangiectasis, Osler-Randall-Weber's disease, and so many things like those. So what I emphasize the students is to go to the latest things in pathology, the latest things in medicine, the latest updates. So that is very, very important. I would not like the students to be backdated and to update their knowledge, because sometimes now new FDA approved drugs, new diagnostic techniques, new criteria for the diseases, and new diseases coming up, and some of the eponyms of the diseases which you have to particularly remember. That's very, very important. Now again, I would just go back to some image-based question. The figure shows a microscopic description of a connective tissue dominated by cells with large vacuolated smooth oval cells with nucleus pushed to the periphery. What is this? What types of cells are these? So you are well aware of the fat cells, adipocytes, lipocytes, which are having, I mean, say the features mentioned in the question: large vacuolated cells, smooth oval cells, nucleus pushed to the periphery, signature appearance. So that would be a classic example of a lipoma if it would be have been a pathological diagnosis, what is to be seen in this tissue. So this might be a predominance of lipocytes, maybe a simple, I mean, say tissue taken from adipose tissue normally, or a lipoma, but not a liposarcoma, because liposarcoma will present something else. So over here, these are the types of questions which you expect, and I guess that you go through these questions, and anytime you find that you have got any queries, my email ID is given. I would be more than glad to answer your queries, and I thank all of you for your concentration, and I hope that this small briefing from my would be very helpful to you as far as your preparation for your NEET PG and FMG questions are concerned. So I wish you that you just go through the books in a very, I mean, say, concentrated manner. You take help of the standard textbooks. You focus on some important topics from very good books. I mean, say, main books like Harrison, Robbins, books like those, Schwartz, Sabston, Anderson, whatsoever the books are there, and they will help you a lot in just approaching to your examinations in a better manner. So thanks a lot, and have a good time.